with these cranial nerves. All right, table one. What is the first cranial nerve? The first cranial nerve, table one.
Olfactory.
Olfactory. You agree that? Table two? You agree? Okay, good. Now, some people say there are 12 pairs of cranial nerves, but some people say no, there are 13 pairs. Comment on that. Anyone? Some people say 12, some say 13.
Why 13? Why 13?
I haven't heard a thing. I haven't heard a thing. I haven't heard a thing. I'm hearing about cochlea. Cochlea is traditional number 8. But the number we are talking about, Doc was trying to tell you just now. You didn't get it from him. Number 0. Number 0, cranial nerve 0. Yes. When is cranial nerve 0 found? When is it present? Yeah. Cranial nerve 0 is present during the first trimester of life. During the first trimester. And it tends to disappear afterwards. So by birth it is not present. And in some animals it is located in the nasal septum. In the nasal septum. So we will say there are 13 pairs in the first trimester. But as time goes by, that 13 pair, which is numbered 0, is non-existent. So when as clinicians we want to test the cranial nerves, and you will have to test the cranial nerves, because when you go to the hospital you're going to find people who have cranial nerve problems, and you have to be able to run through the cranial nerves in an examination so you can see at what level the problem is. And so remember, cranial nerve 0 during the first trimester, and if there is anything of it left, it will be in the nasal septum. Alright? Now, so we use the olfactory traditionally as the first cranial nerve. Table 1. What are the receptors for the first cranial nerve? Come fast. 2. Receptors for table 1. Huh? Receptors for table 1. For cranial nerve 1. The what? Where are these receptors? In the columnar mucosa. Columnar epithelium of the what? Where are you going to find that? Which columnar epithelium? Where is it? Very good. Superior what? Superior what? Superior nasal. This in the can. What is anatomy we're dealing with? You know, why is inside the superior nasal cavity? Why is in the center? Why is the midline? The septum. So the upper third of the nasal septum, and what is on the lateral wall? Superior concave. So it is going to be on the superior concha and in the nasal septum. There you're going to find receptors for number 1. How do you test number 1? Give him something to smell like what? Chlorine? Little bit of chlorine or bromine. Why you won't want to use chlorine or bromine? Well, it is corrosive. So how about a little ammonia? Huh? You won't use that. Why? It smells bad? Well, that is personal. But why won't you use chlorine or ammonia? Because you won't be testing number one. You won't be testing number one. You'll be testing number one and something that is picking up pain. Which is it that picks up pain in the upper part of the nose? It's going to be 5. So you won't use anything with any toxic smell. Anything that can cause irritation. Anything that can cause burning. So how about a little coffee? A little coffee. Or how about some toothpaste? Toothpaste? Well, we can't use that toothpaste. We'd stay with coffee then. Alright, so you can't use anything that is going to irritate. So if the toothpaste is such that it has menthol in it and is going to burn the nose, you can't use that. So you get me? You can't use something that is going to irritate. So onion might be too strong. You might get away with a little garlic, but coffee is fine. Because you'll get the smell and you won't get irritation, and you want purity in terms of what you are testing. So some coffee, nice ground coffee would be smell, good. Alright, so the receptors are in the upper third of the nasal mucosa, so what happens? They are going to be stimulated by whatever you put there, because they are going to dissolve in what? The molecules are going to dissolve in what? Because you can't pick up, you need the molecules to dissolve. So what are you going to dissolve it in? In the mucus produced by what? What produces mucus there? Goblet. That would be thick and sticky. Thick and sticky. You want that up top there? Or you want that in the lower part of the nasal cavity? You don't want goblet up there. You want goblet in ordinary respiratory epithelium. So what do you want up top there? You want stuff from your Bowman's glands, which is watery, aqueous. It can wash off. Alright? So that is going to be the point for stimulating the upper third, where you have your Bowman's glands, which are producing in the columnar epithelium of the olfactory mucosa. And they are going to be stimulated. What other cells we find inside here? Sustentacular and stem cells. Good. These stem cells are going to reform, remake, recreate new olfactory cells, because olfactory cells die. It is one of the places of the cranial cavity where you find olfactory nerves, where you find nerves that are dying. So they don't last for long. They might last for 6 months or so, and they have to be replaced, they have to be replenished. So the stem cells do that. Right. So the signal is picked up and then it runs across to about 20-25 phyla and gets where? Into the bulb. Good. So if you just shoot on this, we can see the bulb. Alright. Yeah. And where's the bulb sitting table to? Where are you going to find the bulb? On the cribriform plate. Very good. And what will happen in the bulb? Synapses on what kind of cells? Ductal and mitral cells. Right. What is the difference? Why do you call it mitral? Because the book said that?
Yeah.
What's a mitral cell?
Electrocyte.
What's a bishop's mitre? What does it look like? Like a little cup. Little cup, yes. Little cup, slanted, you know. So those are the shape of the cells. You have those mitral cells, those that just have one side. Those are the tufted cells. And it is going to synapse on those cells. In the form, you're going to get a little glomerulus form. And then, that is the end of the olfactory nerve. What kind of nerve is it?
Sensory.
It's sensory, but it's in terms of when you take a neuron could be unipolar, bipolar, pseudo-unipolar, bipolar, right? So that's the end of your olfactory nerves, and then from there, what are you going to have? Your olfactory tract. Good. So the tract is going to pick up from the bulb, and it's going to come down. Give me a landmark for the bulb, for the tract. A landmark. Oh, does that help you? I think we need to get the other thing is. You see that nerve better? Yeah, that nerve properly? Yeah. Okay. Good. And tell me a gyrus around that place, then, gyrus rectus. So it is running down, as it were, close to gyrus rectus. Is almost sitting right in the gyrus rectus. And where is this tract going to end? At the vicinity of the anterior perforated substance, right? And what will happen there? That's a trigone, right? Sometimes we talk about the olfactory tubercle. But it is a place where there's going to be like a split. So you're going to have some of the fibers going laterally and some going kind of medially. Some as well with end there. It's found that some are going medially and linking up with the other side. And what they will do is send signals to the other side so that you can get some kind of orientation as to which side the smell is coming from. So if it is coming, the signal is more on one side of your nose, you will know where the dead rat is, if it's on the left side or the right side, right? But the lateral, from the trigone, what will we have? The name is going to change. We have the stria. So nerve to tract going to the vicinity of the anterior perforated substance. And then from there, you'd have the stria. So some are going to go medially and some are going to go laterally, but the significant ones are the lateral ones, which are going to this place right here. You can see that? The uncus, right? So that the vicinity of the uncus. So on the purple, let us just use a different color. We start with the orange in the vicinity of the bulb. Then we go down on the tract until we reach the trigone. And then from the trigone now we split. We go laterally to give you the striae. And the striae will climb up on the medial part of the parahippocampal lobe, gyrus, in the vicinity of the uncus. And there we end the story. It's the only nerve that is going to the telencephalon. Because the next nerve is going to the diencephalon. Alright? So the olfactory is the only nerve going to the telencephalon. The second, which is the optic, is going to go to the diencephalon, going to the thalamus, a section of the thalamus. Sometimes there are patients who have tumors in the nose, cancers that can erode the cruciform plate, destroy the bulb, and produce loss of the sense of smell. Sure. All right. Any questions on one? Table two. Table two. There's somebody there in a plaid shirt on table two. I want to find out how we test for olfactory nerve. How do you test for that? What would you use? Patient has come in and you want to find out if his olfactory nerve is working. What would you use? I'm asking you. We wouldn't want to use anything that is, what is the constraint that we have for the testing substance that we are going to use?
You don't want to use any substance that would cause any like pain or anything. Otherwise, one should just set the special sensation.
Right. You know, you won't want to cause anything that will produce irritation of the mucosa. Okay? Because if you produce irritation, irritation is going to release what? The damaged tissue will release what? When you damage tissue, what would you leave? What would you release? Potassium. Huh? Bradykinin. What will bradykinin do? Cause vasodilatation. And you will get edema of the area. You will get some other substances coming out, SRSA, slow reacting substance of anaphylaxis, adenosine, potassium. What will these things do? They will trigger the nerve, but the nerve they will trigger will not be the olfactory nerve. They will trigger pain nerves from the fifth cranial nerve. So if you use something that is irritative, and the person says, yeah, you still don't know, because he might have a good fifth nerve that is picking up sensation. Alright? So remember the whole olfactory section. This sensation from there for pain is coming from the olfactory, not the olfactory, from the ophthalmic, a branch of the ophthalmic. We soon get down to that. So we would not be wanting to use anything that is irritating the area. So coffee would be good. Or if you have a nice toothpaste there, which is at the patient's bedside, then you can use that. Provided it doesn't have anything which is like menthol, you know, that might irritate the passage. Okay.
If it is coffee you are using, don't use the powder. Use the coffee. Because they have anosmia. If they are not able to smell, they may start taking deep and then go into the nose. So don't use any powders. Not coffee or any, no powders at all. Solutions. And generally, they have a standard water solution that they use is oil of clove. That is a standard in any clinical setting that they use. I don't know if it's available in America, I'm sure it is.
Oil of what now?
Cloves. Oil of
Cloves. Cloves. You should be able to get that. Cloves, you know, little cloves that you, what do you use it for? In baking or making cakes or, huh? Making what? Make ham, put it in ham. Yes. So oil of cloves would be fine. And
I bring some fish. Africans, they can smell it.
alright, so remember that, eh? Oil of cloves. If you want to use coffee, don't use something that is dusty. You know, the patient takes a big pull and copy all over the place. Or he inhales so much, you know, he starts sputtering and causing trouble. So a smell solution, a little bit dissolved in water, should be able to pick up that. And so you can therefore sense whether his olfactory nerve, whether his uncus. For example, if he has there is another thing. Patients who have cancers or tumors related to the uncus can even have different smells, pick up different smells when they are about to have a fit, when they are about to have an epileptic attack. Alright? Okay, so understand the fluidity of the system. The other thing is that the uncus has connections with the septal nuclei. It's close to the hippocampus. People might have different smells that they evoke different stimuli. People use perfumes to evoke different effects. So you have people who use perfumes, for example, to produce different sexual overtones. A lot is used in nerve 1. Alright, so be aware of the connection. Yeah. Okay. Number 2. That's what is number 2? Optic nerve. Now, where does the optic nerve begin? Or just now we said that the receptors for one are in the olfactory mucosa, upper third. So where are the receptors for the 2? In the retina. In the retina. The receptors have their tips in the pigment epithelium. In the pigment epithelium, you are going to find some rods and cones, and they are going to be stimulated by photons. How low is the photonic stream that will stimulate them? How many photons you need to stimulate a rod? 5 photons. 5 photons, yeah. Extremely minimal input. The rods are very, very sensitive. Very sensitive to light, dark stimuli. Will sensitize them. And remember those within the section of the fovea, you won't find any significant number of rods. What you'd find inside there? Cones. And what cones deal with? Cones deal with color, photopic, whereas rods deal with light and darkness. They are scotopic. Scotopus. Yeah. Yeah. That means darkness. Yeah. Light, dark. Right. Photos, they will be stimulated. The cones will be stimulated by colors. All right. So they are in the pigment epithelium. They are going to pick it up and transfer to what? To bipolar neurons. And then the bipolar neurons. Do you need any depolarization in the first section? In the rods and cones, you need depolarization to send the signal.
Yes, I need a gradient potential.
Well, you need none. None in the rods and cones. The rods and cones are so effective for picking up photons. Depolarization would take too long. So it is as if you have electronic transmission between rods. What's the density of rods there? Roughly. About 147,000 per millimeter. 147,000 in a square millimeter. Amazing density. Rods. You have more rods than cones. The ratio of rods to cones is about 20 to 1. We get into a little more of that when we're doing retina. So you're going to send